All right. Perfect start to the afternoon. Thank you everyone for joining us, and welcome to today's National Neonatal POCUS Collaborative Webinar. This is the third episode in a three-part series on lung ultrasound. Before we start, just some housekeeping things. The chat and the audience microphones are disabled. Please use the Q&A feature to post questions, and we will answer those questions during the Q&A session. This webinar is being recorded and will be uploaded to the collaborative website, which is neopocuscolab.com. And now to our main talk. Our guest speaker today is Dr. Almudena Alonso-Ojembarrena, and she is an attending neonatologist at Hospital Puerta del Mar in Cadiz, Spain. Her PhD was on the usefulness of lung ultrasound in bronchopulmonary dysplasia. She has many publications on neonatal lung and diaphragmatic ultrasound, mainly about the use of lung ultrasound for monitoring very preterm infants during their NICU stays. And we are very honored to have her as our featured speaker today. Dr. Alonso, please take it away.
Hello, everybody. Good morning, good evening, wherever you are. Thank you for this kind introduction, Rolling. And if you can see my screen, today's webinar will be running about what can we use lung ultrasound for after preterm infants pass the initial phase of RDS. And we have decided whether to give them surfactant, intubate, or extubated, and so on. So this will be the guide of the talk that we will be going through today. First of all, we will discuss some studies about what's the normal progression of lung ultrasound score in our infants. As you may remember from last talk, lung ultrasound score is a quantitative measurement of the grade of variation that all patients have in their lungs. We use this categories from 0 to 3 to evaluate the rate of variation in different fields, mainly two anterior.
Dr. Alonso, I'm so sorry to interrupt. We can't see your slides.
Sorry. Better now? Can you see them?
Yes, I can see them in Notes view.
In Notes view, okay.
Yes.
So let me check it again.
And
Now?
also, Chris, can you try to see if you can record this? It's not working for me. Please, thanks.
Robin, can you see it in presenter mode now? Thank you.
I'm seeing it in presenter mode. Thank you.
Thank you. Sorry for the technical issues. I was saying that this will be the guide that we will be going through the talk. And we will begin talking about the progression of lung ultrasound score in very low birth weight infants since birth. And for doing this, we will use the lung ultrasound score that was presented in last talk, talking about surfactant administration. This is a paper published in 2019. All studies that I will present today are from 2019 and onward. So it's a very recent references and very recent line of investigation. So I hope that maybe in the next years we will have more ideas on how lung ultrasound progresses in our infants and how can we use them to help our infants. So as I was saying, this is paper in which you can see the progression of lung ultrasound score in infants born before 32 weeks, according to the final diagnosis of BPD or not. In this one, you can see the lung ultrasound performed in the first day of life, 3rd days, and weekly until discharge, or 36 weeks postmenstrual age. And after the initial phase of RDS, in which both groups have high lung ultrasound scores, you may see that at about 1 week of age, lung ultrasound decreases in infants that don't have a bad prognosis and remain low through the whole follow-up. Completely different to what happens with those infants that still that develop need of oxygen at 36 weeks postmenstrual age. So we could say that at about 1 week of age could be like a threshold point in which we can kind of decide or get an idea of how the lung will progress in those infants. But this is not the case in all preterm infants. It's different according to when they are born. In this other paper that included data from different NICUs in Spain, almost 400 infants born before 32 weeks were included, and we analyzed their progression according to gestational age that were born. Here you can see the data of infants that needed oxygen at 36 weeks postmenstrual age, and you can see that the progression is more or less similar, although the infants born more maturely do have lower values of lung ultrasound score, but the progression is more or less similar with the steady values in the first months of life. However, those infants that have a good prognosis and don't need oxygen until the diagnosis of BPD progress differently according to gestational age where they were born. Those born between 28 to 32 weeks do have higher values at birth during the initial phase of RDS, and they decrease afterwards. However, those that are born before 38 weeks do have persistently high values of lung ultrasound scores that begin to decrease after the baby is 1 month of age, as you can see here in these graphs. And this is so even though the infant does need surfactant at birth or not. Here you can see infants born after 38 weeks with persistently low lung ultrasound scores if they don't need surfactant at birth, and if they need it, you can see a decrease in the first week that remains low afterwards. However, infants born before these 28 weeks do have increasingly values of lung ultrasound score until 1 month, 1 month and a half, with a decrease afterwards. But those that don't need surfactant, those that don't have severe RDS, do have an increase of these values of lung ultrasound score at about 2 to 3 weeks of life. And it's 1 month or 1 month and a half when they begin to decrease afterwards. So this is the ultrasonographic representation of what Dr. Alan Jobs and Eduardo Bancalari described in 2012 about the respiratory instability of prematurity. Infants born before 28 weeks, they stay in our NICUs with long periods of needed of respiratory support due to this disease, which has different physiopathology origins due to the initial RDS phase, the need of ventilatory support, pulmonary overflow due to a PDA, muscular respiratory insufficiency. But this is the normal progression of lung ultrasound scores in infants born before 28 weeks. So we have to take this into account when we get to the point of how can we use lung ultrasound in terms of BPD prediction. This is an example of a 26-weeker bone, which is now in the moment of the ultrasound is 2 months of age. And you can see how the lung shows heterogeneous disease. These are anterior, upper anterior, lower anterior, lateral, and posterior fields, in both lungs. And there are some areas with atelectasis, some others are very aerated, and some others show an intermediate grade of variation. And this is something that could be useful, but what we want is to get the diagnosis of bronchopulmonary dysplasia as soon as possible, so as to try to develop efficient treatments for this disease. So using this approach, different publications have came out using both the classical lung ultrasound score that I described before and the extended that also included posterior fields of the lung, which are those more involved in bronchopulmonary dysplasia. So the first paper that came out included 141 patients from French and Italian NICUs, and they evaluated lung ultrasound score in these infants born before 31 weeks at birth, at 7 days, 2 weeks, 4 weeks, and 36 weeks postmenstrual age. And they calculated both classical and extended lung ultrasound score. As you can see, both scores do show different progression if infants develop BPD or not, and the diagnostic accuracy of both values, both lung ultrasound scores at 7 days of life, had good area under the curve, nice sensitivity, specificity, positive, negative likelihood ratios, and positive, negative, positive predictive values, sorry. They also compare when is the best moment to get an idea of the risk of developing BPD and whether if using extended lung ultrasound score does increase the information that we may get from the ultrasound. As you may see here, both measurements provide similar area under the curve until the baby reaches one month of age. So in the earlier phase of the disease, we can use the classical lung ultrasound score, which doesn't need to move or make the baby roll up. This was confirmed by another multicenter study performed in many NICUs in Italy that included infants at 25 to 30 weeks, 141 patients, and the extended lung ultrasound score at 7 days of life showed different risk of BPD in infants according to gestational age, as we described before. As infants born later than 28 weeks do have lower lung ultrasound scores after initial phase of RDS, the higher lung ultrasound score, the higher the risk of developing BPD. However, infants born at 25 to 26 weeks don't really have a high risk of BPD with high values of lung ultrasound score, because I remember they have normal increased values of lung ultrasound scores, as we explained before. We can see in this graph as well. So using these publications and some others, also from Spain, from China, we published 2022 meta-analysis that included these results and get to a pool sensitivity and pool specificity that didn't reach 80%. So it's not the magic ballot, it seems, but it seems that maybe we can increase the value that we get, the information that we may get if we add other variables that we have at the bedside of the patient, like, for example, clinical vitals or respiratory vitals. And in 2021, including a cohort of 300 infants born before 32 weeks, we developed this study in which, taking into account different variables that had to be objective, like, for example, gestational age and sex of the baby, the diagnostic accuracy of this model, this simple model, can be improved just adding the value of lung ultrasound score at day 7. And this was replicated also in a big Canadian cohort study from Mount Sinai that also combined gestational age, sex, and the need of invasive mechanical ventilation in the different moments when the babies were analyzed at day 3, day 7, and day 14. You can see that using a model with clinical variables was improved if we add also the value of lung ultrasound score that the babies had in this moment. So as an example of how we do it in the clinical practice, this is a real clinical case from our unit. This is a female infant born at 25 weeks with this birth weight that was born after by a vaginal delivery. The mother had a suspected chorioamnionitis and she was tested positive for uroplasma parvum. She required intubation at birth and she received 1 dose of surfactant. And this is the first ultrasound performed 4 hours after the surfactant, in which you can see anterior, lateral, and posterior views with nice thin pleural line with lung sliding, A lines, few B lines, and just a bit more in the posterior fields, which doesn't mean worse prognosis. So this is quite good for a 25-weeker. Baby after this remained quite stable, low FiO2, but she had 2 unsuccessful extubation attempts. She was also tested positive for uroplasma parvum, and we gave her azithromycin for 3 days, although we know it's kind of useless. Although she was stable, we, as the political in our units, to perform lung ultrasound at 3 days and 7 days of life to evaluate the risk of developing BPD in our patients. And you can see how the lungs have changed just at 3 days of life, with a thick pleural line, small atelectasis, and increase B lines in all fields evaluated. This was greatly, this was really worse at 1 week of life when the infant showed worse pleural line, worse lung ultrasound score, and this is really a quite worse prognosis, which lung ultrasound is saying to us. So at 1 week of life, the baby was quite stable, but after that, she developed quite a severe respiratory deterioration with increase in respiratory support, and at 36 weeks post-menstrual age, she was still on invasive mechanical ventilation, FiO2 100%, inhaled nitric oxide, steroids, diuretics, and so on. So this is quite just a quick view of what you can do using lung ultrasound in your premise. Now we will have a few words about extubation failure. There's a few publications, not many, talking about the risk of extubation failure in RDS, but I'm afraid that there's no studies published nowadays in infants with evolving BPD, I mean, after RDS. Infants born at 25, 24 weeks that are stuck in the ventilator for more than 1 week or so. We don't know which is the best approach to decide when the extubation should be performed. So we have the hypothesis that maybe we should use both lung ultrasound score and the existence of pre-extubation consolidation. And this is due to the fact that in Spanish cohort, we found that infants that don't develop moderate severe BPD are successfully extubated mostly at about 1 month or so. As you can see in the blue bars are the infants on invasive mechanical ventilation, green bars are those on non-invasive, and yellow are those without respiratory support. So you may see here in this graph, most of these infants are extubated at about 5-6 weeks, but they are still with high lung ultrasound scores, as we described in the first slides of this talk. This is more or less what happens in infants born at 26, 27, but they are mostly extubated since birth. So taking this into account, doesn't seem that lung ultrasound is a good value to decide on the prognosis. So we perform a pilot study using data from 6 NICUs in Spain. These are infants born before 30 weeks and which had an extubation attempt at about 20 days of life. We divided them according to the extubation failure or not. And as you can see, although they had similar respiratory severity scores, they had similar values of gestational age and birth weight. Infants that had an extubation failure did have higher lung ultrasound scores than those that didn't. But you know, maybe without very clinical importance, the difference was not that clinical important. However, if we take into account the number of consolidations that they had, there are significant differences as well between two groups. And also if we divide the patients with extubation failure in the moment when they had the extubation, when they were reintubated, as those that were reintubated after 7 days usually are not due to respiratory disease. So taking these values all together and using a logistic regression analysis to predict extubation failure, if we take into account just the gestational age, birth weight, and the respiratory severity score of the infant, we get an area under the curve which doesn't reach even 0.7. If we increase this model using both lung ultrasound score and the number of consolidations that the patient had before the extubation attempt, we can increase this area under the curve to a value of more than 0.8, which is quite nice. Also to give some examples of how you can do it. This is the pre-extubation exam in a 24-weeker, which we are attempting to extubate at 14 days of life. These are posterior fields in each lung, upper posterior, lower posterior in right and left lung. And you can see huge consolidations all through the fields evaluated that can be recruited just placing the infant in a prone position for 1 hour, as you may see here. So using all this data as to get an hypothesis for a bigger trial, we are now including infants from in a multi-center international study that includes data from multiple centers from Spain, Italy, France, USA, and Canada. And we hope that in the future, we will have more robust data to present you. Some other issues that I would like to talk about today, but a bit more briefly, would be how can we use lung ultrasound to optimize ventilatory support? This is an example of a 24-weeker, both with 7 grams of birth, that didn't develop RDS, but she required a laparotomy at 16 days of life due to a SIP, and she was quite stable. But 3 days after surgery, she's still intubated, but we find that she's with high respiratory settings. We go to check the lungs, and we find a huge consolidation here next to the heart in the left lung. We change the baby position, we increase level of PEEP, we replace we change the position of the endotracheal tube that was too deep, and we are able to recruit this lung. So there's a lot of publications, mainly in the anesthesiology field, about how to recruit lungs with atelectasis and using lung ultrasound to monitor this recruitment. However, this is quite common to find this atelectasis, as you may see here, in infants born at 24, 23 weeks. There are uninvasive mechanical ventilation, quite stable, low respiratory settings, and nice thoracic excursion. So do we have to recruit these atelectasis? Do we have to pay attention to them? We don't know it yet. If the patient's quite stable and it's not developing a respiratory deterioration like RDS or pneumonia, maybe we don't have to give much importance to this. We presented this study in lunch meeting in 2020 in Paris that included 200 patients in different NICUs in Spain. And we get as results that these consolidations are quite frequent in infants born before 28 weeks. Half of them develop them, but only those that appear after 1 week of life, both in anterior or lateral fields, are related to bad prognosis. However, those infants that are more mature don't have consolidations as often, and any location when they're found and any time are related to worse prognosis. So maybe we don't have to give the same importance to any consolidation that we find in our patients. This is the only paper performed in adults or children or whatever on the use of lung ultrasound to monitor the treatment after the acute phase of RDS in adults recovering in an adult ICU. The intervention group received the treatment by their attendings, their nurses, the respiratory therapist, using lung ultrasound to decide when to do nursing, when to change the patient position, and so on. And the control group used only clinical signs. As you can see here, the intervention group had less days of mechanical ventilation, less ICU treatment time, and less hospitalization time. They also had less number of aspiration events and less number of ventilatory associated pneumonia. So maybe in the future, we should do runs of our patients with respiratory diseases using ultrasound, but we don't know the answer yet. Just a few words about NIV withdrawal, in which the only paper published after the initial phase of RDS in extremely preterm infants was from a Canadian group in Mount Sinai Hospital. And this group included infants born before 32 weeks at about 2-3 weeks of life, when the attending neonatologist decided that the baby was quite stable to remove nasal CPAP. They performed ultrasound, and they got this area under the curve to get the information about the risk of the CPAP removal failure. So you can see here the progression of lung ultrasound score in those that had a successful weaning nasal CPAP at 3 days, second week of life, and before the first trial and after the first trial, compared to those that had a failed weaning attempt. They also got this value of lung ultrasound score of 8 points as a threshold to decide whether to remove the non-invasive ventilation in this population. This is an example of how we do it as well. This is a 26-weeker, which is now 1 month of age. She is non-invasive ventilation, but she has the same lung images since she is 1 week of life. You can see this nice thin pleural line, lots of B lines, but we don't see improval. This is not the moment, although she's quite stable, to remove non-invasive ventilation. The moment when you have to decide to try and do an attempt to remove non-invasive ventilation will be when the lungs change to this interstitial syndrome, or even very aerated, in which you will have more chances to remove non-invasive ventilation. What about PDA and lung ultrasound? Well, there are different publications about the use of lung ultrasound to monitor pulmonary overflow in PDA. As you may think, pulmonary overflow can be shown by ultrasound with an increased number of B lines. So all this publication described increased number of lung ultrasound scores in this population with significant, hemodynamically significant PDA. Some others also included data on supplementary material, some others used for other purposes, on the lung ultrasound score in patients with patent closed PDA, or patients with different complications like bronchopulmonary dysplasia, PDA that require treatment, that show different progression in those with different comorbidities. You may see here a decrease in lung ultrasound score after about 1 month. But what are the differences or the similarities between these studies? As you may see here, all of them were performed at different moments of life. All of them have different criteria of inclusion for the inclusion of patients. All of them have different definitions of PDA, but most importantly, all of them, we don't know nothing about the respiratory situations of these infants included. So what we do know is that RDS creates a similar ultrasonographic pattern that pulmonary overflow. RDS, as we heard Dr. De Luca in the last webinar, shows a thick pleural line with an increased number of B lines, or even in some cases consolidations. But we also know that infants born before 29 weeks do develop RDS in most situations, in most cases. So how can we decide if a patient is showing pulmonary overflow due to PDA on an RDS? We are not able to distinguish this quite easy if we don't get information about the respiratory situation of the infant. We also know, as we explained before, that the normal progression of extremely low birth weight infant is to have higher lung ultrasound score, even though RDS is over. So to be able to cope with all these difficulties, we performed this study that was presented in PAS last year and included data of 69 patients with had a pair echocardiography and lung ultrasound in our NICU in the first 2 months of life. And we got that infants born between 28 to 32 weeks do have significant differences in lung ultrasound score depending on the direction of the shunt, for example, or the ductal size, which is related to the value of lung ultrasound score. There were also significant differences or relationship between different measurements related to PDA or lung overflow or left ventricular function. However, if we analyze the babies born before 28 weeks, we are not able to find significant differences in the value of lung ultrasound score, neither other values related to pulmonary overflow or left ventricular function. So maybe in this population, it's not that easy to see the effect of PDA in the lung using lung ultrasound. We also have this paper published a few years ago in which 5 infants born at about 25 weeks had a PDA closure by transcutaneous approach. And the group analyzed both echocardiography and lung ultrasound measurements before and after the procedure. And they showed that both left ventricular output and lung ultrasound score decreased since 1 hour after the procedure until and remain low 6 to 12 hours later. So maybe we can use lung ultrasound to monitor response to PDA treatments, but not to rule out or ruling a PDA. And talking about response to medical treatments will be the last part of this lecture, in which I wanted to talk to you about, for example, steroids. This is NASTRA presented last year in EPSNIC meeting in Athens, in which data from 5 NICUs in Spain were included, infants born at the median age of 25 weeks and this birth weight, were evaluated before we began treatment with steroids, the day they were began with a treatment, 1 day after, 3 to 4 days after, 1 week after the treatment, and then in 2 moments when the baby are already without steroids treatment. As you can see, there are significant difference compared with the basal moment after the babies receive steroids that remains low after that. This is another case, a 25-weeker that required intubation at birth, and she received invasive mechanical ventilation until 1 month, non-invasive mechanical ventilation until 36 weeks post-menstrual age. Different attempts to remove non-invasive ventilation were unsuccessful, and we always get the same value in the ultrasound. We don't see the improvement that we have described that we need to see before trying a non-invasive removal. This is the example. This is the images of her left lung and her right lung. And however, the attending neonatologist decided to begin this patient with steroids. And you can see the improvement in lung ultrasound score and lung images, both in the left lung just 2 days after, and in the right lung as well. This baby that I remember you was more than 4 weeks of non-invasive ventilation, was able to be weaned just in 1 week, and she was able to be in discharge without oxygen. Another treatment that we give for the lungs sometimes is diuretics. And in this paper, we describe the progression of lung ultrasound score in infants that receive diuretics for multiple reasons. All our infants born before 32 weeks. And we divided them according to the clinical response in terms of being able to wean respiratory support. Those infants that here you can see previous lung ultrasound values, and the red box is the one when the moment began to receive the diuretics. The infants that had a clinical response had a decreased values of lung ultrasound score just since the very first moment. And this other paper from an American group also evaluated infants that received diuretics, also VLWB infants, compared to those that didn't, and they showed a decrease in lung ultrasound score since the 3rd day of treatment, also at the 6th day. But they didn't use the classical lung ultrasound score that we were talking about since the beginning of the lecture. They just counted the number of B lines as a difference. So just zooming a bit, we can say that we can use lung ultrasound to monitor the progression of lung ultrasound in our population, in our very low-birth infants, to use it for BPRD prediction and to monitor and optimize ventilatory support. We have robust evidence to do so, but we don't have still enough papers to say that we can use it to predict restoration failure after RDS, NIV withdrawal, PDA, and lung ultrasound, and response to medical treatments, but maybe we will have in the next years. I would like to thank you all for your attention, as well as my colleagues from Spain that are collaborating with us to perform these studies. And now I'm open for all your questions.
Thank you, Dr. Alonso, for that very informative and engaging talk.
Thank you, Robin.
Absolutely. And thank you to our all the panelists who are joining us today for the Q&A session. We will now move to our Q&A expert panel discussion. Please put any questions in the Q&A and I will relay them to the panelists. So joining Dr. Alonso today, we have Drs. Belinda Chan, Monty Sharma, and Nadia Yusuf. To give everyone a brief introduction about our panelists, Dr. Belinda Chan is an attending neonatologist, associate chief, and medical director at University of Utah. She's also adjunct faculty at the University of Utah Hospital Radiology Department and has been the founder and director of the neonatal POCUS program at various institutions since 2018. Dr. Monty Sharma is an attending neonatologist and pediatric pulmonologist at Children's Nebraska in Omaha, and also the director for neonatal POCUS at Children's Nebraska and a part of the CHNC BPD Collaborative. And finally, we have Dr. Nadia Youssef, who is an attending neonatologist and deputy head of the NICU at Paris-Saclay University Hospitals in Paris, France. She is a member of the POCUS working group of the European Society for Pediatric and Neonatal Intensive Care and is a co-founder of the French Society for Pediatric and Neonatal Lung Ultrasound and has published extensively on the subject of lung ultrasound. Thank you so much, everyone, for joining us. And if everyone's ready, I'm going to start with the questions. So one of the questions that we had is, are you using lung ultrasound together with SF ratio, and I'm guessing it is SpO2 FiO2 ratio, in your institutions? If yes, how exactly do you use it? Can you give an example for surfactant?
Nadia, please go ahead.
I'll go first and hello everyone. First of all, thank you, Almudena. It was brilliant. I really learned a lot from your talk. We are actually not using the SF ratio. However, what we are looking at is the oxygenation index, which also gives in another way information about oxygenation in the body. And we are using arterialized capillary blood gases, so it's fairly easy for us to get that. It's not that invasive as compared to arterial blood gases, just something we rarely do unless we have an inline arterial catheter. So to answer the question, we're not using that exactly. However, we are combining oxygenation indexes when needed with the lung ultrasound picture. And we have still not applied Francesco Raimondi's team and the just newly externally validated predictive score for that. What about you, Almudena? Have you started using it?
Well, we don't use it neither. I think that using a value that you are using to predict surfactant cannot be used also in I don't know how to explain it. There's a bit of collinearity between lung ultrasound score and oxygenation index, so maybe it's not the best approach. Usually, when you see the indication of surfactant using ultrasound is quite clear, but maybe in more difficult cases, you can rely on some oxygenation measurements as well, but usually they're not necessary. You can just rely on the ultrasound images that you may see.
Thank you for the speakers. Next question is, how do you approach quality assurance in POCUS for lung ultrasound scores in this population?
You mean inter-observer agreement or so?
I guess the question is in general about quality assurance. Do you typically involve radiologists with you, or do you have pediatric pulmonology to maybe cross-check the lung ultrasound scores? And how do you ensure that, including what you mentioned, the inter-observer agreement, how do you make sure that is being practiced?
Almost sounds like more from a clinical application, right, as opposed to research-based inter-observer variability. And that is something that we had to work quite a bit with here, just because radiology leaves the lung ultrasound really out of their field, right? They say to us that that's not something we routinely do. If you want to do something with the diaphragm, of course we'll review it for you. But if it's lung scores, that sounds like a foreign world to us. So we really do have to get together as a group every 2 weeks or so and review all of our images and try to standardize at least what we're doing. And that can sometimes be a struggle, right? As far as like what machine are we using? And we've talked about this in some of the other lectures, that as you get better and better and better, the machine doesn't matter. The probe might not even matter, but for us, it did require standardizing things so people could learn and just eye train themselves, right? Like get their eyes used to what they're seeing. And now it's become better and better, where if you do, for some reason, end up with a different, like a curvilinear probe for some reason, people are now in agreement with each other at a clinical application level.
I think I'm very jealous of people in Europe because lung ultrasound is the routine practice. And then that's why all this amazing paperwork have been done by Nadia and Almudena coming on from Europe. In America, like there's strong evidence based on all these papers that Nadia and Almudena published that there is a good evidence to support the lung ultrasound in predicting like BPD, RDS. However, like how do you translate into clinical practice? There's something that I personally, in my unit, that struggle. You have to have something that's so common. You have to, and so time sensitive. How do you train enough people for all the neonatologists to use that to learn ultrasound and to use as a clinical practice? That is more challenging. FiO2 people are familiar with, easy to do, anyone can do that, but lung ultrasound is a much harder to do in a clinical setting. And then as Monty said, you have to standardize it at the beginning. That process takes a while. And then what kind of machine you use, and hopefully in the near future that become part of the standard of practice. Instead of listening with a stethoscope, you use the lung ultrasound, which is as non-invasive as a stethoscope, but give you more information, and hopefully that will get to that point. But for right now, as people have asked, like, how do you standardize? Yes, it takes time and takes all these people who is listening to this talk come and participate, and then have collaboration, and then have expert in the field to write some guidelines or standardization or recommendation, more education in order for a real clinical practice. So
I will
Thank you,
say
Dr.
that
Chen.
just as an addition, pediatric pulmonologists are even farther behind neonatologists when it comes to using pediatric or just POCUS in general. So if anyone's interested in introducing it to pulmonology, I am open to all comers.
Monty, can I say something? You have to
Yes.
become, be part of our French group, the JEP. JEP stands for Group for Échographie Pulmonaire Pédiatrique. We use the word echography for all kinds of ultrasound. And we are actually multidisciplinary in pediatrics. And let's say our two co-presidents are actually pediatric pulmonologists. So, there is hope for
So you're
pediatric
saying there is
pulmonologists in
hope
the
for
US. Also, there is
pulmonologists
hope
here.
for us all. Yes, there is.
Thank you, everyone, for your input. I have a very interesting question. Next is, again, about the practical application of lung ultrasound. The question is, I seem to have a hard time differentiating between score 2 and score 3, and perhaps sometimes see an almost score 2.5 appearance on lung ultrasound. So how do you navigate through this? Which category would you place those images in?
Can I go first?
Yes,
I
please.
think that really reflects real life, because if we compare to adults where they actually only have the possibility of seeing, well, sometimes a little more than one intercostal space, we actually see larger areas. And we do know, especially in the beginning of life, that the lungs are heterogeneous and aeration is not done in a homogeneous way. So there may be, I have a very pragmatic approach. I've been using the lung ultrasound score since, many years now, 8 years, I guess, since the first paper came out. And sometimes it's clear cut. Sometimes you're kind of in between. And it's true. In the beginning, we're saying, why don't we do like 1.5 instead of when it's between 1 or 2, or 2.5 instead of 2 and 3. This is real life issues. And what's important there is not just the figure, the number in the end. What's important is your global overview and what it means as an indicator of loss of aeration. It is true that we have thresholds, so for surfactant 9 and above, but in the end, what matters is your appreciation, and with experience this comes. So what I do in my clinical practice is I'm pragmatic, but a 0 for me is a normal lung, almost, meaning that I would have A lines and hardly any B lines, so less than 3 B lines per intercostal space. A 1, I would have a mix of A and B. but like you really see your A lines. It's not like a tiny little A line that's kind of hidden behind the B lines. The two is when you don't see the A lines anymore or hardly any. But again, some adult authors have gone through using a more horizontal approach, also saying if you have 25, 50, 70%. So I think the main message here is we are dealing with numbers, but these numbers only mean anything when we know what they stand for. They stand for loss of variation. And sometimes it is true. We are kind of in between. So sometimes you might give a score that is between 7 and 8, for example, or 9 and 10. So it's a real life answer to a real life question, I guess.
I think Nadia brings up a really important thing in my mind, because this is where tracking your internal outcomes is so important, because then you are taking into account that global picture. Like, hey, we all scored that a 9 and we gave that kid surfactant and outcome X happened. Or, hey, we were debating on this and outcome Y happened, right? So then you can kind of learn from it institutionally, like, okay, well, we're all thinking that this is this, you know. Initially, we used to joke that we'll just tell the learner they're wrong, but we found that it tends to be more contentious. As more and more people learn it, there's more and more disagreements. And so I think just having some way to follow what you're doing is really important, whether it's in a QI methodology or maybe even just through QA, just have some outcomes in mind.
Yeah, and it's
I
also
think
a question of, sorry, Almudena, go ahead.
No, finish you first.
It was just, completing what Monty was saying. And what we're saying is basically it's also with experience. It's also a kind of pattern recognition. But go ahead, Almudena. Sorry, I interrupted you.
No, I was just saying that this is true. This is a clinical question that many people, mostly at the beginning, perform, but maybe differentiating between 2 and 3 is not the most tricky thing. Maybe between 1 and 2 is more difficult sometimes. But for this purpose, I can say unofficially that there's actually nowadays an international consensus going on in which people from adult settings, neonatal children, ICUs are getting to a final consensus of what's the final definition of 1, 2, 3. So maybe we will have more details to learn with maybe at the end of this year.
I think the data that Almudena presented kind of echo what the question stated is there's a variation. All the data you presented, there's a trend of the mean that's different, but the variation or predictability, like variation of the score can go from 5 to 10. It's a really big range. I think it's kind of speak with either the machine, the user, or like the scoring between 2 to 3. And hopefully in the future, rather than just a subjective score that is so categorical, is there a way that you use density, or even the buzzword nowadays is AI? Can we use AI, the amount of density that can actually be more telling than just between 2 to 3, especially to give us a little bit more detailed, granular information for lung ultrasound?
However, and not to make you scared if you're beginning, if you are able to learn lung ultrasound with someone at your bedside, the inter-server agreement of lung ultrasound score is quite good. There are a few indices that have such a big inter-server agreement in terms of semi-quantitative and quantitative evaluation. So don't get scared. You can be if you have something to learn from, it's something that's quite easy. Although sometimes you may have some difficulties.
You all. And I guess speaking of local scoring variation, in the surfactant and BPD meta-analyses, each lung ultrasound score cutoff is different and ranges from 4 to 12. And Dr. Jorgensen's article suggests each NICU may need to do their own validation. This seems to be maybe a problem. Data suggests that there is not one lung ultrasound score cutoff we can all use. So in your opinions, each NICU needs to validate with local data. I guess, what would be your opinion on that?
in my opinion, you can only use something that's published if you use it the same way that the article describes. If you have a meta-analysis, an article, study, or whatever that describes a methodology and you want to apply it to your NICU, you have to use it the same way. If you want to change it because you want to use different fields, different machine, or different settings, you have to validate it in your population as well. But lung ultrasound score is the same in any. I mean, it's the same for people in the USA and people from Europe and whatever. The thing is that I don't know why, humans tend to use different methodologies and try to get the same results doing it in a different way. This is quite common with lung ultrasound scores, in which you can find the original publication by an RDS group that included 3 fields, 2 anterior and 1 lateral, and you can find other publications using different fields. Of course, you will have different scores because you are using it in a different way. If you want to apply something to your NICU, you can do your validation in your NICU as well. But if you use the same methodology from the original study, you can use it as well in your population.
So much. And I guess we can take a couple more questions. Our next question is, has identifying patients at risk for BPD by lung ultrasound led to different management strategies and earlier use of interventions such as steroids, diuretics, or PDA management?
We hope so, but we don't have the answers yet. We don't have any specific treatment that's effective enough for BPD apart from steroids in the first week of after the first week of life. So we need now a clinical trial that uses some features of lung ultrasound to see if we can reduce BPD just in those infants with high risk. We don't have the answer yet. We are now in one of our lines of investigation one of our lines of investigation are going that way, but we are not.
Yeah, and I guess the other, I know we lost Almudena there, but I think it's that definition of BPD, and I don't want to get into the philosophical thing there. It's such a heterogeneous disease, right? Like a Jensen grade 1 is very different than grade 3, but even if you look at the grade 3s, only 30% of them end up getting a tracheostomy, which, is like trach is like a 4-letter word in the NICU. So those kids are different too. And I think that's one of the things that I'm really curious about is, well, are there things we can follow almost as a biomarker using ultrasound in the grade 3 BPDs that give us a better idea of how our interventions are working, right? Whether it's like, hey, as this kid grows, this is improving, this is not improving, or hey, this is what was different between the kids who ended up needing a tracheostomy as a grade 3 versus the ones who didn't. Because again, I think that would really help us longitudinally follow them, like maybe more precisely than a stethoscope and a chest x-ray. So I do think that that's one of the big things that I'd be curious to get your thoughts on, Almudena. I know we've been working on trying to get everyone into the BPD collaborative, but I'm really hoping for those people that are in there that we can do some of these prospective studies with centers that do have credentialed providers looking at some of these questions. Like, how can we use this and leverage this tool and separate this out? Because, I mean, when you talk to most parents, they would much rather have a patient who doesn't have a tracheostomy. And if there's a way for us to better follow this, I think counseling would be easier for me as a pulmonologist, as a neonatologist. I think therapy following would be better, right? Like so many of my kids are on 6 months worth of steroids. And I don't know at what point did something just stop changing and we just left it and just adjusted it, right? But if I had some sort of biomarker to follow, like, hey, look, the RSS isn't changing, the respiratory severity score isn't changing, my lung ultrasound isn't changing, well, let me wean that steroid now, right? Like it plateaued at some point. So I do think that would be an interesting route to investigate. I think you're on mute, Almudena.
Sorry for leaving the room. I don't know what happened. The idea is that now with
Dr. Alonso, you may want to speak up or maybe adjust your mic. We can't really hear you much.
Sorry.
But I
Better. That's better. Thank you.
Thank you. The idea is that now with lung ultrasound, you have a new tool to monitor your infants since birth, non-invasively. That it's more, it's at least as useful as X-ray. You can do it every day if you want. You're not harming your baby. So you can have information on what's the best position of your baby, how the lung is progressing, is it improving, is it not? Does the steroids improve in your lung of your baby? Is it not? Are diuretics being successful or not? So this is something that we don't know if this would change general management of this population. We don't know it yet, but maybe in the future this would change our clinical practice.
I think lung ultrasound is still a lot of research need to be done, because now we have been doing a lot of data gathering, kind of correlating lung ultrasound with a lot of clinical finding. So, but then the next step will be, how do we use it to change our clinical practice and transform new care, which need more research before we do to that step. For example, if I have a baby who is just born, preemie, is on like 45% of FiO2 or even intubated, why do I need an ultrasound to predict the baby needs surfactant? The baby will need surfactant, but that's the borderline, maybe 32%. You can use lung ultrasound to decide on surfactant maybe a few hours earlier. That probably will be transformed care. And Almudena give a really good example of his unit. It's like the baby seems well, but how come the lung ultrasound image was getting worse over time? Then it helped to predict the deterioration of the baby a couple of days before. That probably will be more useful than saying that, oh, okay, like I have a baby who's mechanical ventilator for like 2 months. Do the baby gonna have BPD? Most likely. Do I need an ultrasound to predict it? Maybe not. But will 7 days gonna change the practice? Could be. Is there early management in earlier that we can do to make that outcome change? That hopefully that will be the future. But I think we need more people who's interested in this area, getting more data so that we can correlate with our research with change of practice.
I guess we are out of time, but thank you all, and thank you to our wonderful speaker and panelists for this wonderful discussion, and thank you all for joining us. As previously mentioned, this is the 3rd episode in a 3-part series on lung ultrasound. Unfortunately, there were technical difficulties in today's webinar and recording today's webinar. And if the recording was successful, it will be uploaded to NeoPOCUS Collab website in the next few days. In the meantime, the first 2 webinars in the lung ultrasound series are available on the NeoPOCUS Collab website. We will be taking a summer break from our webinar and office hours series, but please join us again starting at the end of August for a new season of virtual education. And if you're interested in receiving communications about future educational opportunities offered through the collaborative, subscribe with your email at the website. Thank you again, everyone, for joining. We'll see you next time.
Thank you. Bye.
Thank you. Bye-bye.
Bye. Thank you all.